The details of the Toronto outbreak, as I mentioned, were described in a number of publications. This is one, the Morbidity Mortality Weekly Reports of CDC from May of 2003, discussed in some detail the cluster of SARS cases occurring in healthcare workers in Toronto in April of that year. Here's a look at characteristics of 11 healthcare workers who had symptoms of SARS after exposure to the index individual during the time of his intubation in Toronto in April of that year. And as you can see, a number of persons here, respiratory therapists, ICU nurses, ward physicians, ICU physicians, charge nurses, radiology technicians, etc., either were around the person during, before, or immediately after intubation in the ICU, and likely were exposed as a result of aerosols that were generated at that time. It was also felt that there were problems with regard to especially removal of personal protective equipment and contamination that was likely to have occurred during that process, as individuals were not as attuned as they should have been perhaps to the details of that process and how to remove PPE without causing additional exposure to skin or mucous membrane surfaces. So that particular outbreak raised the point that donning and doffing, or placing on and removing personal protective equipment, was absolutely critical in the protection of healthcare workers, and that as a result, various checklists for how to put on and remove the equipment were developed, and the procedures themselves became very highly choreographed. There was a lot of detail added, or specifically how to put on what segment at what time, when to remove it, and exactly in what order, such that, again, contamination would not occur. And also developed was the process of using trained observers, so that mistakes were less likely to be made during the process, with feedback being given continually to help prevent additional errors from occurring. The attention also focused on aerosol producing procedures, the use of the following approaches probably impacted the transmission rate: the use of nebulized medications, diagnostic sputum production, induction of sputum, bronchoscopy, endotracheal intubation, airway suctioning, the use of positive pressure ventilation like CPAP or BiPAP, and high-frequency oscillatory ventilation. All of these put individuals at risk who are in the immediate environment, and inform us of the need to use appropriate protection if such procedures ever were to occur with an individual harboring a highly virulent organism. In the next segment, we'll look at some additional aspects of the Toronto experience.